We're going to start off our talk today with a clinical vignette that illustrates some of the points relevant to this discussion. Then we're going to discuss just some brief things about the neurosurgical history of normal pressure hydrocephalus. We're going to talk about prevalence and pathophysiology. We're going to talk about how to form a differential diagnosis and discuss some comorbid conditions that may exist with this illness. Imaging considerations, how we treat the disease, what the prognosis is like, and finish with some conclusions. So here's our case that's going to illustrate some of the topics that are relevant to this. 61-year-old woman presents complaining of 2 years of progressive difficulty with walking, cognition, and she also has occasional urinary incontinence. Her past medical history, basically she has some mitral valve prolapse and some hearing loss, also has psoriasis. On examination, she has no signs of myelopathy. It's always important to check for myelopathy in elderly patients with difficulty with walking because that can also produce difficulty with walking. She's oriented ×3. She does have some difficulty with short-term memory. She can only recall 1 of 3 objects with distraction after 5 minutes. And her gait is shuffling, wide-based, and she has in-block turning. All right. Let me see who all's here. I'm going to ask some questions. Let's start off with Joyce. Joyce, what do you think of these 2 MRI scans, this T2 weighted axial image and this sagittal T1 weighted image? What do you think of those?
Yeah, so in the first T2 axial image, there's enlarged temporal horns, and in the sagittal, you can see ventriculomegaly in the lateral ventricles.
Okay. So ventriculomegaly, she has particularly enlarged temporal horns. That's an important thing to notice. And she doesn't have a lot of hippocampal atrophy, despite the fact that she has enlarged temporal horns. She also has bowing of the corpus callosum, and the corpus callosum is quite thinned. As you mentioned, the ventriculomegaly is apparent here. So NPH is characterized by gait apraxia, cognitive decline, and urinary incontinence. That's that classic triad of symptoms that is classic for the disease. Of course, as we'll discuss, some patients only have 1 of those or 2 of those. The incidence varies between studies, but may be approximately 1 in 200,000 per year. So that means 1 in 200,000 people per year are diagnosed with the disease. But shockingly, I've found a couple of studies that show that up to 1 in 10 patients in memory care facilities may be affected with NPH potentially. This is a controversial, surgically treatable, potentially cause of dementia. I say it's controversial because some people initially doubted the existence of this illness. We'll talk a little bit about that in the history part. But in general, it is commonly treated now with shunting. So let's get on to the history, as we just mentioned. So this was first described by a Colombian neurosurgeon whose name is Solomon Hakim, and also a neurologist from Harvard named Adams. Hakim was actually, he moved from Columbia to Boston to the Leahy Clinic to do a fellowship in neuropathology, and he did a lot of autopsies, and he noticed that some of the patients that he autopsied for dementia, they had enlarged ventricles, but they didn't really have atrophy. The atrophy was not very prominent, but the ventricular enlargement was prominent. So he was confused by this and started to research this more, and he found that that some people were affected by hydrocephalus later in life, and eventually monitored pressures and found that these pressures were normal. Now, he is seen in this picture pointing to these equations, and the reason I bring these equations up is because, his theory of the pathophysiology was that the brain, as the ventricles enlarged, there was increasing force on the walls of the ventricle. Because even if you have a normal pressure, if the ventricles are enlarged, the area is increased, and pressure times area equals force. So his theory was that there was more force on those white matter tracts surrounding the ventricles. And of course, the white matter tracts that are more medial and closer to the ventricle ependema are the white matter tracts that go to the lower extremities. So this was his theory on why the lower extremities were preferentially affected. And this is just an illustration to say that if you have, you can get a lot more force from the same pressure if you increase the area, basically, and that was his theory. But let's talk now about pathophysiology. So that was his theory, this idea of tissue distortion back in the 1960s, Hakim's idea. But since that time, people have found that the pathophysiology of normal pressure hydrocephalus is probably more complicated than that. Obviously, there are some structural changes, but there could be alterations in cerebral blood flow. There could also be changes in the interstitial fluid pressure. Factors like this can affect the failure to drain off vasoactive metabolites and toxic metabolites that may cause some of the white matter changes around the ventricles. So there could be white matter changes there due not only to ischemia, due not only to transependymal flow, but also due to toxicity in the area next to the ventricle. Whenever we're diagnosing normal pressure hydrocephalus, this is especially for the medical students too, you need to consider a broad differential. So one of the problems with diagnosing normal pressure hydrocephalus is the symptoms that we expect, which are difficulty with walking, difficulty with cognition, and urinary incontinence are three symptoms that can occur as a result of aging. So also people that are older that are diagnosed with normal pressure hydrocephalus, you also want to consider, could they have some other neurodegenerative disease such as Alzheimer's disease, Parkinson's disease, Lewy body dementia? Is vascular disease causing multiple strokes, periventricular white matter disease, and things that are causing loss of function? Another correctable, a medically correctable cause of dementia and difficulty with gait, of course, is B12 deficiency or vitamin deficiencies. Whoops. And then finally, you can consider some infectious possibilities such as syphilis or HIV, and you could also consider depression in the elderly causing something that's called pseudodementia, where a person becomes very depressed and sort of abulic and doesn't participate. But really the clinical diagnosis hinges on these three symptoms: gait apraxia, urinary incontinence, and cognitive decline. Some people call this the terrible triad. So first, let's take each of these in turn: gait apraxia, urinary incontinence, and cognitive decline. Gait changes they're really required according to the 2005 International Committee guidelines. If you want to diagnose this, the person has to have gait changes if they're ambulatory. So it's not, if a person presents with only dementia, but their gait is normal, this is very unlikely to be the diagnosis. Not only do they have an abnormal gait, but it's abnormal in a very specific way. They have magnetic gait, meaning they don't lift their feet up off the floor. They take short steps that are broad-based with their toes turned outwardly. Compare this to one of the other things on the differential diagnosis, which is Parkinson's disease, where the feet are actually closer together. I don't know if anybody here has ever seen someone with gait disturbances from Parkinson's disease, but they take these very small sort of mincing steps that are with their feet quite close together. In long-term case series, the symptom of gait has actually been the symptom that has shown the most reliable improvement with shunting. And there are some specific tests which the residents will recommend, or which the residents will remember, because we do these in the hospital, which are the Tinetti score, the timed up and go test. These are, and there's some pretty decent evidence that these steps, particularly the Tinetti score, does a good job of predicting somebody's risk of falling. In other words, if your Tinetti score is less than 18, your risk of falling is pretty high. Now let's talk about the urinary urgency, urinary incontinence issue. So it could be mild or profound. I saw a patient the other day who had a pretty convincing picture for NPH, but does not have urinary incontinence, for example. And for some people, it's a really prominent complaint. Patients may have comorbid conditions with their urinary symptom that confounds this diagnosis. So in men, a lot of times they're advanced in age, they may have had a history of prostate cancer or benign prostatic hyperplasia, and this can also lead to urinary issues. Some women that are elderly will have problems with pelvic organ prolapse and problems with pelvic tone that affect this diagnosis and basically some things that predispose them to urinary incontinence. And improvement with treatment is more variable for urinary incontinence than it is for gait. And in fact, in a couple of series, urinary urgency and incontinence were the symptom that was least likely to improve with treatment. They have done urodynamic studies on NPH patients that demonstrated detrusor muscle overactivity as the primary finding. This sort of makes sense from the standpoint that you can imagine there's this pressure on the white matter tracts in the brain, so the brain is not able to place an inhibitory effect on the detrusor muscle function in the bladder. And in some studies, as many as 90% of patients have shown improvement in urinary incontinence. So that's a bit conflicted with what other studies have shown. So it is possible to improve this symptom, and I've seen it in some of our patients, but in general, gait is the thing that improves most. Cognitive decline, this is a good one to speak about specifically because cognitive decline in patients with normal pressure hydrocephalus usually is not in the form of a severe dementia with speech impairment. And this makes sense because most of the dysfunction in normal pressure hydrocephalus is subcortical. You're really affecting mostly the white matter tracts and the subcortical fibers, and it's disproportionately affecting the frontal lobe. So you get decreased concentration, psychomotor slowing, but because you have this absence of cortical phenomenon, you really don't have, for example, aphasia, agnosia, apraxia, for example, a lot of patients with neurodegenerative diseases like Alzheimer's disease have a profound apraxia. They get lost. They can't do a trails test when it comes to neuropsychological testing. These are all signs of agnosia, apraxia, these cortical functions. Notable also is the absence of hallucinations and delusions. These can be present with Lewy body dementia. They can also sometimes be present with depression presenting as pseudodementia. So people with NPH generally do not have hallucinations or delusions. Of course, people can have as many diseases as they please. So sometimes these illnesses are comorbid. And we actually did have one patient that had Lewy body dementia and normal pressure hydrocephalus, and we treated her with a shunt, and she had quite an improvement in her gait. There's no stepwise progression of the dementia whenever you take their history. This is more characteristic of a vascular dementia. And in one study it's important to note when it comes to cognitive decline that, as I mentioned a moment ago, people can have more than one disease. And in fact, there was this study from Germany where they did biopsies on patients that were undergoing ventricular peritoneal shunt placement, and about a third of those patients did have biopsy-proven Alzheimer's disease. Neuropsychological testing, other than showing that it's a subcortical phenomenon, can have some limited value in diagnosing and assessing NPH. In general, neuropsychological testing is going to show slowing on timed tasks, difficulty with divided attention, executive dysfunction, so that's a frontal phenomenon. they're going to have disproportionately preserved recognition memory. I just will show this example of the Stroop test. So the Stroop test is where you set up a conflict. So you ask a person to say what color the letters are, and you show them these two pictures. First, you show them this one, and they say green because the color of the letters are green. But then you show them this one, and the color of the letters are red, but the word says green. So it takes them a little longer to say red. But and this slowness in saying the word red will be more exaggerated for the Stroop task a lot of times in patients with normal pressure hydrocephalus. So just as you can't use neuropsychological testing or even clinical criteria to get a definitive diagnosis of normal pressure hydrocephalus, you also cannot definitively diagnose this condition with imaging. So there's no single imaging finding that's going to predict responsiveness to shunting and prove that a person has this disease. MRI and CT scan are very useful. You can look at the ventricular size. One way to do this in a quantitative way is to look at the Evans ratio, which is the ratio of the maximum frontal ventricular width divided by the biparietal diameter. Some patients have had PET studies as well. There's now a PET study that allows you to look for amyloid, for beta amyloid, which can help determine if a patient has signs of Alzheimer's disease. There are also studies that can evaluate the change in cerebral blood flow in response to acetazolamide, but the role of this study is still uncertain, so it's not done very frequently. They used to frequently do CSF cisternograms where they put a nuclear medicine tracer into the lumbar cistern using a lumbar puncture. But really, these have been mostly abandoned because they're not really found to give any predictive value that's superior to just clinical symptoms and MRI imaging. As the picture I showed earlier and Joyce interpreted, noticing that these lateral ventricles are large, so particularly people with NPH get disproportionate widening of the temporal horns, and the cutoff some papers uses 6 millimeters. They have this characteristic bowing of the corpus callosum, which we saw in my patient as well. There's an acute callosal angle, so this angle becomes more acute. And all of these, as well as dilated sylvian fissures, crowding of the convexity gyri, and periventricular white matter changes, these can all help corroborate a diagnosis of normal pressure hydrocephalus. It's also important to note one thing that people have examined quantitatively in some detail is this stroke volume through the aqueduct on proton density T2 images. But as of yet, they have not been able to really quantitatively use this to predict shunting response. So the take-home message here is imaging is useful. Neuropsychological testing can have some use. And then finally, all these tests can be useful along with the clinical picture, but none of them are definitive. So let's talk about some adjuncts. So these are invasive things that you can do to try to help prove that somebody has normal pressure hydrocephalus. So one thing you can do is you can have the patient walk, have them walk 12 meters or so, and then you do a lumbar puncture and drain 40 to 50 milliliters, and then you have them walk again about an hour later, and then some studies even do it a day later. This is called the lumbar tap test. So that's why I put the spinal tap picture here. So the problem with this is it's not a very sensitive test. So as the medical students know, if your test is not very sensitive, it's not very good at ruling it out. So in other words, if the tap test is negative, you still can't really effectively rule out normal pressure hydrocephalus, but it does have a fair specificity, so that if their walking does improve with the tap test, then there is some that has some predictive value. And in some studies, they actually showed the positive predictive value for the tap test, just a tap test alone was about 86%. in general, most places encourage you, if the lumbar puncture test is negative and the clinical picture is otherwise convincing, to consider further workup. And usually that further workup now consists of an extended lumbar drainage trial. So in this trial, the patient is admitted to the hospital, usually for about 3 days. They have a lumbar puncture, and then we thread a tube into the lumbar cistern, this small tube about the size of a pencil lead. And then we drain about up to 10 milliliters an hour. It's usually starting at 5 or 7. And then we do repeated gait assessment with drainage. We do post-drainage neuropsychological testing. And the numbers are a bit all over the place because there's a bunch of different case series of people examining their results with extended lumbar drainage, even some pretty recent ones. There's a pretty big series from Toledo, about 100 patients they did this on. But in general, it seems like the sensitivity is about 80%, the specificity is about 90%, and the positive predictive value is around is in the 90s as well. But this is more onerous for patients. It's higher cost, potentially higher risk. One study quotes a 1 in 3 risk of meningitis. We haven't really seen that here as of yet. But all of these tests, the lumbar puncture test and the extended lumbar drainage test, the point of doing those is to try to determine if a patient is going to respond to a shunt. Now, you might say, you've talked a lot about shunts. What about medical treatment? So the neurosurgery residents probably aren't asking about that because they know there's not really good medical treatment for this. But in general, most of our conditions, we consider medical treatment before we consider surgical treatment. And indeed, people have done this for normal pressure hydrocephalus. There's actually listed on clinicaltrials.gov. There's actually in Israel, there is an open trial, supposedly, of randomizing patients to acetazolamide versus placebo to see if it treats their NPH. This trial was supposed to be closed in 2019, but I can't find any literature that where the group has published their results yet. But they may be still in the process of analysis. But as of yet, we don't know of any medical treatment for normal pressure hydrocephalus. Memantine, an NMDA antagonist that is frequently used for Alzheimer's disease and other types of neurodegenerative diseases, dementia, may be helpful for some of the psychiatric manifestations. And there have been several studies where they prospectively do a case control. So patients that come to them and want a shunt, and patients that come to them that decide not to have a shunt, but they feel like meet the criteria. They have followed these patients prospectively in a longitudinal fashion. And in general, the patients that undergo conservative management have had poor results. Of course, this is not the same as a randomized study, but it does provide some level 3 evidence. So the primary treatment, the standard of care treatment, if you do think somebody has normal pressure hydrocephalus and you've made the diagnosis with imaging, and you've made the and they have the appropriate clinical symptoms, you've done a lumbar puncture or a extended lumbar drain trial, and you've decided that this patient does seem to have normal pressure hydrocephalus and you want to treat them surgically, the surgical treatment that's most common is the ventriculoperitoneal shunt. There have been some case descriptions of treating this with endoscopic third ventriculostomy. There have also been some case descriptions discussing lumboperitoneal shunts, but in general, most people are currently doing ventriculoperitoneal shunts. Now, the best evidence we have for this right now is actually level 3 evidence, these prospective case series. There have been some trials, but they have not been randomized. So we don't have level 1 evidence for this yet, and probably never will, because of the fact that it would be very hard to convince somebody to enter a conservative arm if they really felt that they had this. So patients are selected usually through imaging and the lumbar drain trial, as I mentioned. Gait seems to be the most responsive symptom. So I've said that probably at least 3 times in this lecture. So that's a point we're really emphasizing. Urinary symptom improvement is variable. It's kind of all over the place in case series. And cognitive improvements have been quantified in relatively few studies. So surprisingly, a lot of these patients that they have longitudinal data on, they have not done rigorous neuropsychological testing for long-term follow-up. As somebody said, I can't remember if this was in the spine conference, that nothing ruins success like follow-up. Well, in the case of NPH, there is some problems with the durability of this treatment. So several studies have shown a decreased responder rate after only 6 months. There was one study that was pretty disheartening that showed that about 50% of people that were no longer responsive after about 18 months. Now, this is, of course, the caveat to this is you didn't remove the shunt after 18 months, even though they weren't responsive. So if you removed the shunt, you might find that they're still even worse off than they are, because it may be a progressive illness and the shunt is making them better. It's just that they've gotten worse, if that makes any sense. But in general, we need to do better long-term follow-up on these patients in neuropsychological testing. Now, some people might be inclined to think that a ventriculoperitoneal shunt is a relatively minor procedure, but it has real risk, and it has real risk, particularly in this population, which is usually elderly and often has comorbidities. So the risk, the main one that we worry about as neurosurgeons is subdural hematomas. So I've been showing you this lady's images all along. She did undergo a shunt. She did well for several months, and then she came back complaining of new symptoms and was found to have these subdural hematomas. And we had to turn her dialer shunt up and actually drain this one on the right. Shunt failure is also a risk. You can get infection, you can get hemorrhages, intraventricular hemorrhage, intracerebral hemorrhage. All of these things are risks. And the initial complication rate, as you might imagine, 30 or 40 years ago was very high for this illness. They had no adjustable shunt valves. There were, there was a lot of difficulty with it. But even in, for example, in this 2012 multi-center trial, the Symphony registry, basically, spelled SINPHONI, was the adverse event rate was 22%, and some of these adverse events were pretty bad. Things like pneumonia, subdural hematomas, infections. So it's not a risk-free procedure, especially in this population. So I did mention adjustable valves a moment ago, and do adjustable valves make a difference? I don't know if they make a difference in a lot of patients with traditional hydrocephalus, but there are some trials that have compared valve types for NPH. They're not randomized, but there's some low-level evidence that using these adjustable valves with anti-siphon devices may confer, it should be confer, not confirm, some advantages. So that in general is our standard here at this center. So in conclusion, NPH it's a poorly understood and potentially reversible cause of neurological impairment in adults. Its diagnosis is difficult, but sort of the cornerstones of diagnosing this illness are CSF drainage, neuroimaging, and exclusion of other types of neurodegenerative diseases. And then currently there are not really any medical treatments that are supported. I did mention that randomized trial in Israel. I'd be curious to see what the results of that are if they ever publish it. Perhaps they haven't recruited enough patients yet to do the trial. There is some evidence supporting treatment with ventriculoperitoneal shunt. It's level 3 evidence. And basically what I'll say is, when this works, it's great. When it doesn't, it's not great. But I've definitely had, and I think every practitioner that takes care of these patients, they've definitely had patients that have done remarkably well with this treatment, and then they've had some patients that, despite the treatment being technically done well, the shunt being in place and working properly, it didn't really seem to improve them very much. So I'm going to exit out of this and go back to the this and stop sharing here. Okay, what questions do you guys have for me? Is everybody asleep?
That was a good talk, Wendell.
Oh, thanks. Thanks. Yeah. So I guess the key thing to note here is that, you know, the disease is still not completely understood. There are definitely patients out there that you can help, but you have to really discuss the risks of the surgery with the patients, and you really have to do a good job of working this up. You know, you at the very least, you need to do imaging and a spinal lumbar puncture, and then rule out some of these other causes of dementia. All right. Well, thank you guys. Sorry I was late. I tried to talk really fast since I was running late, but I got done too early. So I'm sure you guys will find something else to do with the time.
One question, Wendell, it's Larry.
Yeah, sure.
Is there anything that you've changed over the past since fellowship that you've changed in terms of diagnosing these patients that you feel that's successful?
Well, the reason I did this talk, to be honest with you, is because I wanted to read a lot more about, I wanted to read the trials comparing extended lumbar drainage to the trials for the TAP test, you know, spinal tap test, and also there's also another test that I didn't discuss really extensively in this, but basically it's an infusion test where you actually see how much pressure. If you set a certain amount of pressure, you see at what rate their spinal fluid will drain out of a lumbar drain, and patients that drain despite having a pretty good pressure opposing it, seem to do better with shunting in some trials. So that's one of the reasons I put together this talk, is I wanted to read all of those trials and look at that. And as I read over these, and part of the reason I wanted to do that is because we've had several patients that have been admitted to the hospital for an extended lumbar drain, and they've gotten confused and disoriented in the night. They've wanted to leave, or they found it very uncomfortable, and they've been very unsatisfied with the lumbar drain. So there's always this question in my mind, which is, you know, do you really need to do an extended lumbar drainage trial? And after reading through these trials, there is some pretty good evidence for the extended lumbar drain trial, and it does have a better sensitivity than the lumbar puncture test. But I think in the future I'm going to be more aggressive with working patients up with basically a lumbar puncture and a walking test if they have really convincing symptoms otherwise, and then kind of move on to an extended lumbar drain trial for patients with less convincing symptoms. Is sort of, so that's a long answer to your question, Larry, but that's one of the things I'm thinking about modifying in my practice is using the extended lumbar drain predominantly for people that have a more confusing picture.
Thank you.
Yeah. Anybody else have any comments to make or questions? All right. Well, you guys have a great evening. All right. See you guys.